or it implanted some information that the patient now has to consider before they directly answer a question that I asked. Okay? An example is, patient told me that the assault happened at the entrance to her apartment. Okay? When in reality, it happened at the entrance to her apartments. That was a very subtle difference, and the defense attorney then claimed that the patient kept changing her story when she realized that it didn't fit. The entrance to her apartment implied that it was at the door to her apartment, and she described in great detail that there were bushes. He pulled her into the bushes. She had scratches on her. She pointed to the scratches saying, see, this is where I got injured, being pulled into the bushes. And the defense attorney maintained that she had changed her story when she realized there were no bushes there to substantiate, when in reality it was the entrance to her apartments, the grand entrance, which was covered with bushes and trees and areas. So that tiny little detail almost lost the case. And so it's important to remember that once they start talking, don't come in and try to clarify. The other thing is that I'm often asked in court, well, do you really think that she's that naive that she didn't know XYZ? One of the things that we ask is, did he ejaculate? We intentionally use that word. I want to see if the person looks at me and goes, I don't know what that means. Then I'll do a step down. Do you know if that he came, or did he have an orgasm? And still is naive and unsophisticated enough sexually that they don't know what that means. Patients who get raped from behind assume that they're raped anally. So they'll talk ad nauseum about how they're raped anally, yet all their injuries are around their vagina. They think because they were raped from behind that it was anally and not vaginally. So it's really important to let those pieces of information and silence, as we're waiting for them to answer, happen. And so try as much as you can to not jump in and clarify. Good times to clarify are after the forensic history is completely over, okay? And it's always good to know when that is. So feel free to always ask, when in the form do you want to know that I know something? So those are reasons to really look at being as quiet as you can, schooling your facial features. If they think that being raped orally is something that is unacceptable, and that's a common thing, is that they don't want to tell us they were raped orally, and maybe you choose that time to try to stifle a yawn, and she interprets that as potentially disapproval. Okay, doesn't know you were trying not to yawn because it's 3 o'clock in the morning and this is your 5th case. Okay, so again, do clarify information that you have, and this is assuming you have consent to talk with the nurse, which that's something that we get right off the bat. But do it in private. Okay, you will have some form of documentation occur as a result of this interaction. What you see at the time of the exam or the assessment may or may not be the final piece of documentation. As a rule, the documentation or the full report does not go to the advocacy organization to be put into their files. Okay? That would then negate a large part of your confidentiality, your privilege, that you then have all that information in your files. So you just want to be careful about what you have and how you document and such. The forms in Washington State are not mandated. There is no standard form or format. You may have check boxes. You may have a combination of check boxes and narrative. You may have fully narrative. We use fully narrative dictation. So our standard report is usually about 6 to 10 pages long, single space typed, that we dictate and then is typed out by somebody for us. Okay? Okay? It's important that you understand what questions are on there and why the questions are there. The nurse should be able to tell you why she's asking any given question. And I can remember in the very beginning, I asked, when was your last period? And are they regular? Are they roughly every month? And that caused the advocate to pull me out into the hallway and say I had no right to be asking that question, that I was just being nosy. So that allowed for a good teaching moment with the advocate. And I talked to her about how I have to explain the risks and benefits of emergency contraception. That if she has regular cycles, then she's going to have the most common fertile time period, which is 4 days mid-cycle. And the risk of not taking emergency contraception during those 4 days would be much different than if it happened the day after she finished her period. So having those type of dialogues and conversations are really important. When did you first start having sex? Very important if I'm looking at trying to determine if I have a healed injury, not healed injury, or if the